Well, it's a good morning for us, and it is a good evening for Professor Davis, who is across the world in Australia. So, welcome. I'm Dr. Stephanie McNally. I'm the medical director at the CATS Institute for Women's Health. And thank you this morning for joining our Mary and Richard Slone Grand Rounds. This is a topic near and dear to many of our hearts, and we really look forward to having a robust discussion about menopausal hormone therapy, symptom relief, or metabolic disease prevention. At the CATS Institute, our mission is to improve the health of women across their lifespan, bridging the gap between wellness and personalized care delivery. We are advancing women's health every day by providing expert, coordinated clinical care, educating our community on prevention and well-being, and supporting sex and gender-specific research. Aligned with Northwell's mission statement, the CATS Institute is a convener and an amplifier of women's health with system initiatives focused on improving health outcomes for women and ultimately leading to a healthier woman, healthier families, and healthier communities. We are breaking the mold with our approach by optimizing health of women focused on 6 foundational elements: the practice of medicine, empowering women to make informed decisions, sparking the conversation to improve women's health, prioritizing sex and gender-based research and education, educating future researchers and healthcare professionals, and advancing leaders and promoting gender equity. Our ecosystem includes over 100,000 experts in women's health, as well as ways that we connect with our community, our ambassadors, and through our social media channels showing evidence-based information. A special thank you to Mary and Richard Slone for their generous support of this program. The Sloans have been longtime supporters of Northwell and women's health. These grand rounds are educating current and future generations of our healthcare providers on the latest advances and scientific breakthroughs. Our attendees today will receive CME credits. Northwell Health is jointly accredited by the ACCME, ACP, and ANCC to provide continuing education for healthcare providers. At the end of the program today, there will be a link, but you must complete your survey and evaluation within 48 hours. We have a disclosure form, which we adhere to strict ACCME standards for integrity, and all of the participants in today will share their financial disclosures and relationships. These are our disclosures for the course director, and Professor Davis will share hers. During the webinar, feel free to ask questions. It'll be a Q&A feature, and then we will get them at the end of the webinar. Now it is my absolute privilege to introduce Professor Davis. But before, a teaser for next grand rounds, which, believe it or not, will come at the end of our summer holidays on September 1st. Rebecca Thurston, who's an Associate Dean of Research at University of Pittsburgh, will be here discussing women's behavioral health topics. So now, without further ado, Professor Davis. She's a clinical researcher and internationally recognized expert in sex hormones across the female lifespan, including perimenopause and menopause. She is the head of the Monash University Women's Health Research Program and holds prestigious National Health and Medical Research Council of Australia Level 3 investigator grants. She is a consultant endocrinologist and head of the Women's Endocrine Clinic, Alfred Hospital, Melbourne, and executive council member of the Australian Academy of Health and Medical Sciences. Her resume is robust and her research is detailed. With over 495 peer-reviewed publications, her work underpins many best practice recommendations and has influenced healthcare delivery globally. She advocates for care via co-authorship of international best practice guidelines and led to the development of a nationally and internationally endorsed practitioner toolkit for managing menopause, work that we follow on a day-to-day basis. She has received numerous national and international prestigious research awards, including the Australian Heart Foundation Ross Hohen Award in 2022, among others. It is with great pleasure an incredible honor to introduce Professor Davis. We are thrilled to have you and look forward to your discussion today.
Oh, that's a very kind and very generous introduction. So thank you very much. Now I'll try and share my screen now, which should work. But of course, it's never going to be perfect, is it? We had it all up before. So I'm just going to make sure this is going to work perfectly and get this up. And is that sharing for you? And I don't know what you're seeing. Can you confirm that for me? You can
Yes.
see it?
Perfect.
Okay.
Yes.
Okay, so I'm going to talk about menopause hormone therapy and how it connects with cardiometabolic health. These are my disclosures, and any of my group's data that I'm going to present will come from NHMRC, National Health and Medical Research Council funding, but I do have honorary consultancies that are listed here. So normally we talk about our colleagues at the end, but I think it's really important to highlight colleagues at the forefront of my talk, because none of the research I do would be possible without an incredible team. And these are the particular members of my team who have contributed to some of the studies I've included in this talk. So we traditionally have thought about sex hormones as being specific to one sex. And I'm going to cover both estrogens and testosterone in this presentation, because both estrogens and testosterone are important in women and in men, but I am confining myself to speaking about women. And the aspects I'm going to talk about is the contribution of estrogens and androgens to cardiometabolic health, as in terms of their contributions as endogenous levels, what we understand about the cardiometabolic changes that emerge at menopause, and I'm going to summarize these. Does menopausal hormone therapy prevent cardiometabolic disease, and what is the role of testosterone in terms of the cardiovascular system in women? So estrogen has important cardiometabolic effects, and it's really important to acknowledge these are not gender specific. And we learned this from the aromatase knockout mouse model. So in order to make estrogen, you need to have a functional aromatase gene. If the aromatase gene has a mutation or is knocked out, then the animal or the human is estrogen deplete. So on the left is the aromatase knockout mouse, and not the fat one, and the slimmer one is the wild type mouse. And the aromatase knockout mice are characterized by obesity, insulin resistance, they have fatty livers, and here you can see on the left the liver of the fat cells of a wild type mouse, and on the right the fat cells of a knockout mouse, a big fat juicy fat cells in the Arco mouse. They have decreased lean body mass, and their obesity is not just nutrition intake or metabolism, but in fact they move less. So when there's a beams placed across their mouse cages, they actually move less. So there's a very distinct phenotype of an estrogen deplete rodent. What about humans? Well, there have been a handful of men that have been described with aromatase gene mutations. This particular man from Brazil was identified because he presented with osteoporosis. Initially was treated with testosterone, and that did nothing, and then was further investigated. At the time of diagnosis, he was young, 29, but had carotid artery plaques, abdominal obesity, hepatic steatosis, type 2 diabetes, with insulin resistance characterized by pigmentation with acanthosis nigricans. And you can't see it, you have to trust me here, but in fact, when he was treated with estrogen, the manifestations of insulin resistance and dyslipidemia reversed, and his neck acanthosis nigricans resolved. This shows you his liver biopsy before and after estradiol therapy. So you can see the fat engorged liver cells on the left and not so on the right with treatment with estrogen. And his left common carotid artery plaques resolved with estrogen therapy when the dose was increased to 50 micrograms per day patch. So it's really quite a remarkable example of what estrogen depletion does in humans. There have been a multitude of studies, which I'm not going to go into detail about, describing genomic and non-genomic pathways by which estrogen reduces dyslipidemia and impacts vascular function, glucose disposal, folding of insulin in the pancreas before it's excreted, endothelial function, cardiac muscle function, etc., and protection against inflammation and injury. So virtually ubiquitously throughout the metabolic and vascular system in the body, estrogen has really important effects. So then one would expect if women have estrogen insufficiency, there should be cardiovascular disease risk reduction. And I'm going to talk about, firstly, clinical features of young women who have estrogen insufficiency, notably women with functional hypothalamic amenorrhea and premature ovarian insufficiency, and then move on to menopause. So one would expect that elite female athletes would have excellent cardiovascular function. However, it's been documented by several different studies that elite female athletes with amenorrhea actually have impaired endothelial function and more adverse lipid profiles compared to athletes who remain having regular menstrual cycles. And this is looking at flow-mediated dilatation in women with functional hypothalamic amenorrhea compared with eumenorrheic women. And because all the forest plot lines are to the left of center, it basically shows that these women have less flow-mediated dilatation. And a very recent study looked at 12 weeks of estrogen replacement with 100 microgram per day releasing estradiol patch versus placebo in women with functional hypothalamic amenorrhea who are athletes, and looked at flow-mediated dilatation. And in fact, there is no benefit in terms of vascular hyperemic reactivity with estrogen replacement in these women. And I think the message here is that functional hypothalamic amenorrhea involves thyroid dysfunction, hypercortisolism, and dysregulation of leptin and GnRH and kisspeptin in the brain. So estrogen doesn't fix these problems. This is a complex condition. It is not simply estrogen deficiency. And these other hormonal dysfunctions are actually contributing to the vascular irregulation in these women. And we also know simply giving these women estrogen doesn't fix their bone loss either. The best way to fix these women's bone and their vascular health is to get them menstruating again. And that's because when they become eumenorrheic again, all the other aspects, the thyroid dysfunction, the hypercortisolism, etc., has resolved. So what about POI, premature ovarian insufficiency, which is ovarian failure before the age of 40 and early menopause before the age of 45? And there's study after study, observational study, that premature ovarian insufficiency and early menopause are associated with increased cardiometabolic disease and, in fact, premature death. But again, we've got to look at the causes of these conditions. It's not that all that's happened is that women have lost estrogen. The causes of POI are autoimmune, iatrogenic, genetic, and when you look at idiopathic, there's usually 1 in 3 have an affected family member, so it's ultimately an undiagnosed genetic cause. And as I said, it's not simply estrogen insufficiency, but a complex condition. So it's naive to think that just giving estrogen is going to fix everything when you've got this background of disease causing the problem. So the point I'm making here of these conditions affecting young women, the underlying etiology is actually heightened cardiometabolic disease risk. It's not just estrogen. Although we know that in early menopause and premature ovarian insufficiency, there's an increased premature cardiovascular disease and early mortality, there's not a single robust longitudinal study proving that estrogen replacement actually reduces cardiometabolic disease in these women. However, we still strongly recommend estrogen for these women to protect their bones and potentially protect their cardiovascular health. But there's no guarantee it will protect their cardiovascular health completely. So moving on to menopause, again, without going into detail, well-documented cardiometabolic changes are seen in postmenopausal women compared with premenopausal women. And they're all listed here. The one people talk about most and women talk about is the increased central abdominal fat. We do see steatotic liver disease. There are vascular changes, endothelial dysfunction, increased insulin resistance and dyslipidemia, and all of these increase cardiovascular disease risk. We do know that if you give postmenopausal women estrogen, it has cardiometabolic benefits. All listed here, I'm not going to read through them all for you. Even improved sleep will have cardiometabolic benefits. So it's sort of a pleiotropic effect in terms of estrogen. And as a consequence, we see a reduction in cardiovascular disease risk profile. The question then is, does this reduce cardiovascular events? And that's important to consider. Does estrogen prevent cardiometabolic disease after menopause? So much maligned, but still the best study we've ever had access to is the Women's Health Initiative. And reminding those who aren't familiar with it or the details, it enrolled women aged 50 to 79 years. It was designed in the 1990s, and the primary outcome was, did estrogen prevent cardiovascular disease? Women who had a uterus were given estrogen and progestin, 16,000 women, and it was stopped in early 2002 because of a breast cancer concern. The hysterectomized group got estrogen only, 10,000 women, and that was stopped, and the reason is controversial, but the purported reason was an apparent increased risk of stroke. This was not a low-risk study sample. This was not a pristine group. The majority were either overweight or had obesity in both arms of the studies. Approximately 40% were past smokers, and you weren't excluded if you had a prior cardiovascular event. So as you can see here, 6% in the estrogen progestin arm had no cardiovascular disease and 12% in the estrogen-only study. So they were fairly representative of the population in this respect. During this study, where women received estrogen and progestin, there was a lower incidence of self-reported type 2 diabetes in the treatment arm compared to placebo, with no difference in the estrogen alone versus placebo. However, the graphs look great, but the devil's in the detail because you've got to look at the y-axis. The actual annualized incidence difference was minuscule for placebo versus estrogen progestin. And the cumulative incidence difference over the 5.2 years of the study was less than 1%. So yes, it looks exciting if you look at the graphs, but in absolute numbers, not really. And then if you look at the actual study, so this is the factors associated with incident diabetes in the estrogen plus progestin study. It looks pretty if you look at this forest plot. However, placebo compared to getting HRT was associated with a hazard ratio of 1.3 of incident diabetes. Having a waist circumference more than 88 centimeters compared to less than 88 centimeters had a hazard ratio of 3.57. So this would suggest, and that's after adjustment for treatment allocation and age, etc. So this would suggest that if you wanted to prevent diabetes in this population, you wouldn't worry about giving them estrogen. you would actually look at the waist circumference and look at ways of reducing that. And this reduction, minuscule reduction in incident diabetes, did not translate into reduced cardiovascular events during the study. So what was seen is that there was no difference in cardiovascular events between the active and placebo groups in all age groups during the study. Only women who were more than 20 years post-menopause exhibited any evidence of harm with treatment. So this idea that you cannot start estrogen if women are older than 60 or more than 10 years from menopause is not borne out by this data. Estrogen only during the study, about 7 years, resulted in no reduction in myocardial infarction or death, and there was no harm in starting estrogen at any age in the study. Again, really removes this concept that estrogen after the age of 60 is going to be bad for you. So if we summarize this, for diabetes, moderately less for estrogen progestin, nothing estrogen only. Coronary heart disease, neutral. Stroke, there was this funny blip of an increased incidence of stroke in women who got estrogen only age 60 to 69, but not in women aged 70 to 79, which calls that a little bit into question and not seen in the estrogen plus progestin arm. So this basically says no benefit, but probably pretty safe. VTE, however, is increased with oral estrogen therapy unquestionably, and about double in each age group. Then they followed women up out to 13 years from randomization. So an extra 6 years from the estrogen only study and 8 years from the estrogen progestin study. What's lost in the detail of this follow-up data is the number that actually are included in the analysis. And we don't know where approximately 20% of these women disappeared to. And the data basically reports a risk reduction by 13 years of follow-up in the women who received estrogen only. I would argue, I don't know what happened to the other 22%, and is this really real? Because we don't know whether the other 22% had events or not. And again, overall, no evidence of harm at 13 years from randomization in the women they were able to follow up. In the cumulative 17 years follow-up, there was no risk reduction in cardiovascular disease mortality, but again, no evidence of harm. And you've got to say, altogether, we're talking about 27,000 women in these studies. So if you need more women than that to show a benefit or harm, the risk effect or the benefit effect must be very, very small. So why didn't estrogen prevent heart disease in these studies? Well, maybe they used the wrong estrogen. It's possible. We know estrogens all act via the same receptors and the same non-genomic pathways. They're all metabolized ultimately to other estrogen in the body. Oral estrogen has first pass hepatic metabolism. It increases clotting factors. It also is better at increasing HDL cholesterol and lowering LDL cholesterol than transdermal estradiol, but it may increase triglycerides, and it increases VTE risk. Transdermal patches do not get the first pass effect, and there's no increase in VTE risk. But looking at in more detail, the WHI study used conjugated estrogens. These are actually quite fascinating. There are about 250 steroids in conjugated estrogen preparations, and only about 60, or 230, and only about 60 have been defined. And it's a real estrogen cocktail, and also contains non-estrogenic steroids that combine both estrogen and androgen receptors. So I put out there that a lot of the claims of benefits of estrogen in WHI, for example, supposedly a risk reduction in estrogen only in young women in the 13-year follow-up, or a lower instance of breast cancer in the women who got estrogen only may be specific to conjugated estrogens, because there's not a single study showing these so-called benefits in women treated with transdermal estradiol or oral estradiol. So the naysayers of WHI will say, oh, conjugated estrogens are terrible, we should never use those again. Oh, but estrogen prevents breast cancer when it's estrogen only. And forget that the estrogen that had low risk of breast cancer was actually the conjugated estrogens. So you can't have it all ways. Oral estradiol is less dependent on GI absorption, likewise rapidly converted to estradiol, estrone and estrone sulfate, and these are all back converted into each other right throughout the metabolism of estrogens. Non-oral estrogen are not metabolized during the absorption. Less is converted into these other estrogens, estrone and estrone sulfate, that's dropped off. And there's an enormous variation in the absorption with transdermal estradiol. Patches and gels have wide variations in absorption within and between individuals, which can be quite problematic. Maybe estrogen was only going to be beneficial for women with hot flushes and night sweats. And there have been a few studies linking vasomotor symptoms to greater cardiovascular disease risk. I'm not going to go through them. They're all observational. They all report surrogate endpoints, and the outcomes are mixed and the findings are inconsistent. Very recently, there has been an analysis of the participants aged less than 70 years in WHI who had moderate to severe vasomotor symptoms at baseline, and there was no benefit of estrogen only over placebo in terms of atherosclerotic cardiovascular disease events. So there appears to be no benefit specific to women with hot flushes and night sweats. Then there's the whole argument that maybe estrogen's only protective if started very early after menopause, and if you start it when women are in their 60s, you've missed the boat. So the KEEP study was done looking at the effects of both oral and transdermal estradiol versus placebo, started within 3 years of menopause on carotid intermediate thickness, and that's what the graph shows. But they also looked at progression of coronary artery calcification and epicardial pericardial adipose tissue volume. And there was no benefit of either estrogen approach, transdermal or oral, over placebo during 48 months of follow-up in 727 women. The ELITE study, early versus late, looked at giving oral estradiol within 6 years of menopause versus after 10 years of menopause in nearly 600 women with, again, a 4.8-year duration of the study. And they used oral estradiol with micronized progesterone or placebo. And the outcome was carotid intermediate thickness, and there was a small difference seen between active and placebo in the women who were less than 6 years post-menopause at the outset. The absolute difference between groups was small. In the women more than 10 years post-menopause, there was no harm but no benefit. It's noteworthy that the majority of these women had previously used HRT, many more than in the women less than 6 years post-menopause, which may have impacted benefit. In terms of the benefit, the magnitude of the effects seen with estrogen in the women less than 6 years post-menopause was equivalent to a separate study by Wildman and colleagues that looked at the effect of a 4-year diet with exercise in terms of lessening of carotid intermediate thickness. So the benefit was not great. And one could argue, if you wanted that benefit and the woman didn't have menopausal symptoms, they might be better off on the diet and exercise. And then there's the meta-analysis, the Boardman meta-analysis, which was published in the Cochrane database. And if you look at this, it's pretty exciting. A 48% lower risk of coronary heart disease in women who commenced estrogen within 10 years of menopause. which was not seen in the lower section in women who commenced after 10 years from the different studies. However, the devil's in the detail. Look at the number of events. We're comparing very few events because events are not that common in these age groups. The absolute risk reduction, of course, over this analysis was risk from 1.8 to 1.1%. And again, I'm not sure you'd be advocating a lot of therapies for a 0.7% risk reduction. And then if you take out the Danish osteoporosis prevention study from the analysis, there's no benefit. The Danish osteoporosis prevention study was what it sounds like. It was an osteoprevention study. It was open label. There was no placebo group. Women knew if they were taking hormone therapy, and there was no follow-up in terms of compliance. Now that's problematic to me because these, something like 40% were smokers. They were given 2 milligrams of oral estrogen, and there was a very, very low venous thromboembolic disease event rate. So a very low DVT event rate, which is surprising for postmenopausal women on oral estrogen who also smoke, which brings you into question the compliance in this study. So if you take a fairly sanguine approach, I would say the evidence is not there that starting estrogen early prevents cardiovascular disease. Between 2000 and 2020, following WHI, the use of estrogen therapy declined dramatically in all age groups, as did heart disease mortality. And if this was stopping smoking, you'd say that would be great. I expect that result. But if taking estrogen prevents heart disease at a population level, you would not expect this result. So again, this calls to question, at a population level, does estrogen prevent cardiovascular disease in postmenopausal women? And I suspect not. Why? Well, postmenopausal women are not totally estrogen deplete. Rodents don't make DHEA sulfate and DHEA from their adrenals. Humans do. DHEA sulfate is the most abundant hormone in humans, sex steroid in humans. And after menopause, it goes into the circulation, is taken up by a multitude of tissues where it's converted within cells into estrogen, acts as estrogen in those cells, and is re-released into the circulation and then can act in other parts of the body. So women do not live the rest of their lives in complete estrogen depletion, as often described. So then we need to go back and look at the menopause and the whole story of the menopause. And I'm as guilty as anybody of doing a number of studies comparing postmenopausal women with premenopausal women and postmenopausal women with estrogen therapy versus postmenopausal women without estrogen. And until really recent years, we've ignored the menopause transition because it's too hard to study. It's really difficult documenting when a woman is perimenopausal. We're trying to do that now for a study, and I can tell you it's really tough. So the menopause transition, by the current accepted guidelines, which we are challenging, it starts when cycles vary by becoming shorter or closer together, but our data suggests that it starts probably when they also become lighter or heavier. And the menopause transition ends with the final menstrual period. The formal definition of perimenopause is that perimenopause ends 12 months after the final menstrual period, so 12 months after the transition. The Swan studies really focused our attention on this space much more. And the menopause transition is not an estrogen deplete state. This is data from the Swan study where women were followed longitudinally with 3 blood samples per week for 4 weeks every year for 49 years. And these are estradiol levels clustering in different groups. And for 45% of women, estradiol levels are significantly greater in the 5.5 years before their final menstrual period than prior to that time. And yet our data, and this is 5,500 when we're fully characterized, shows you that hot flushes and night sweats start to increase even when women are making a lot of estrogen. And if it was all about estrogen depletion, you would expect that in the years after menopause, you would see that the prevalence of moderate to severe hot flushes and night sweats would be increasing, not decreasing. So this is sort of strange. In our study, women reported moderate to severe weight gain commencing from the early perimenopause and maximal in the late perimenopause. And women are really reporting that they don't like fat around their tummy. And what does the SWAN study show us? It shows us that visceral adipose tissue gain actually accelerates in the 2 years before the final menstrual period. And then the rate of accumulation, although it continues, the rate slows. And that matches what our women in our surveys tell us, that all the changes happening from the early menopause into the early peri to late perimenopause. So two completely different populations in these studies. And body composition from SWAN, this is a smaller number of women, 1,200 women. Body composition, again, starts to change before the final menstrual period when women are still making estrogen. Sleep disturbance starts in the early perimenopause. This is our data, 5,500 women, a representative sample from across Australia, and this is the SWAN data. And if you look at the trouble falling asleep, the frequent wakening, this all starts in the early perimenopause and then persists in the postmenopause, but doesn't worsen, which is really fascinating to me. And then from the cardiology perspective, endothelial dysfunction starts to emerge in early perimenopausal women. So if this was only about estrogen insufficiency, we should be seeing it emerging and accelerating later in the menopause transition and accelerating even more greatly when women become profoundly estrogen depleted. That doesn't happen. So I believe we need to be looking beyond estrogen to understand the emergence of cardiometabolic disease in women. And I know that my colleagues at SWAN are really picking through their data to find out what else is going on there and what else can their very detailed data tell them. Should you tell your patient at increased cardiovascular disease risk to stop estrogen? Well, these women were in WHI and there wasn't an increased event rate. There didn't seem to be harm. And I would suggest the answer would be no. Treat their cardiovascular disease risk. This is a really elegant study involving 86 women average age of 51 years, and they wore skin transducers and had their heart rate and blood pressure and pre-ejection period monitored. And this is what happens when they're asleep. Now, the red dots are the interesting ones. They're the women who don't wake up with a hot flush, but the transducer can actually tell their skin temperature's changing. The grey wake up with a hot flush, and the blue ones wake up once the hot flush has really happened. What you can see is that, particularly in the ones that wake up, there's a significant increase in heart rate. There's a very significant increase in systolic blood pressure, an increase in diastolic blood pressure, and a reduction in the pre-ejection period. So there are cardiovascular changes that matter occurring as a consequence of a hot flush and the cardiac sympathetic activity. And I think I would rather my patient have this not happen if they're at cardiovascular disease risk by treatment with non-oral estrogen therapy than have this happen if they're having this happen repeatedly through the day and the night. This is a meta-analysis in women of the data for women with cardiovascular disease. And the biggest study of these was Stephen Hulley's study published in the 1990s. But the meta-analysis suggests from randomized controlled trials of women with pre-existing cardiovascular disease, while there was no evidence of protection, there was no increased event rate in terms of myocardial infarction. It was non-fatal, B is fatal cardiovascular events, and C is stroke. So again, this is very reassuring for you treating women with high cardiovascular disease risk or pre-existing cardiovascular disease, that estrogen therapy, if they're highly symptomatic, is probably not going to do them any harm. Non-oral estrogen does not increase VT risk. I heighten at approved doses because there are extraordinary number of women now being treated with doses that have never been studied. High doses from questionable practices, and I can feel confident saying that non-oral estrogen at approved doses does not increase VT events, but I don't know about some of the doses that are being prescribed. And in the final couple of minutes, I'm going to talk quickly about testosterone, which is everywhere. Apparently everywhere in New York or on the East Coast of America. So this is recent data from our group, MassBeg. Testosterone blood levels do not significantly change at menopause. And what we see in an older study of ours of 600 women and our more recent study of 1,100 women, very well characterized. And these are women not on hormone therapy, not on glucocorticosteroids, they've got at least one ovary and so on and so forth, that we see this nadir in testosterone in women at about 60 years of age, which is sort of interesting. In 700 women well characterized, age 40 to 70, we found no relationship between testosterone and lipid levels and insulin resistance. We have found that women treated with testosterone implants who are already on estrogen, we see increased flow-mediated dilatation and also increased flow with GTN after administration of GTN, which was a surprise. And this is a sort of funky study we did where we gave women 3 different doses of inhaled testosterone. Their blood levels of testosterone increased within seconds. They were all supine and their blood pressure fell. So 7 of the 12 women in the study had a fall of more than 10 millimeters of mercury with an acute dose of testosterone. So testosterone is a vasodilator. It increases from the age of 70 years. We do not know why. And in this study, this is from the Esprit study, so it's 5,500 women with a median age of 74 at baseline, followed up with adjudicated cardiovascular events over 4.5 years. And we found that women whose testosterone blood levels were in the lowest quartile, or DHEA levels in the lowest quartile, had a 2-fold greater risk of a major adverse cardiovascular event in the follow-up. Don't ask me why. We did find in women in this study that women whose testosterone levels were in the upper 50th centile had higher HDL cholesterol and lower triglycerides. We did not see this in women at an average age of 50 years. So testosterone is not associated with cardiometabolic disease risk in postmenopausal women. It is an acute vasodilator and enhances vascular endothelial function. There's provocative data that endogenous levels that are lower are associated with increased cardiovascular events, but this might be testosterone being a surrogate marker for overall better health, and is not evidence that testosterone will prevent heart disease in women. And just to conclude, we keep looking at hormones, and there's so much more than hormones. And this was the point of my first digression into premature ovarian insufficiency and functional hypothalamic amenorrhea, that we've got to look beyond hormones and at other aspects of sex differences. It may reside in sex chromosomes. It also may reside in other risk factors that are unique to women. Age of menarche, menstrual disorders, age of first pregnancy, age of last pregnancy, preeclampsia, gestational diabetes, what happens at midlife, stress, work, life. And we've got this naive view that you're going to give women estrogen, and as your previous head of the FDA suggested, will reduce cardiovascular events by 25%, is completely naive. Because not only that is we've got all these other factors that are happening, and we know that hypertension and diabetes and smoking are so much worse for women than for men in terms of cardiovascular disease risk. And then all these new factors that we're looking at now in terms of heart health for men and women. So these are my conclusions. I will not read through them all. I do not believe estrogen should be prescribed to prevent heart disease. I do not believe that there should be a sort of a censure that no women over 60 should have estrogen, or that women more than 10 years from menopause can't have estrogen. I think that's based on belief, not data. And we do need to understand testosterone better in women, but giving testosterone, to my mind, does not prevent heart disease. And I will stop sharing.
That was incredible, and a review that really parses out the fact and the fake, where we've taken things to an extreme. So there's some questions that I received and some in the chat to kind of piggyback on that testosterone. When you're looking at values, because many of us are trying to undo the pellets, and to your point, on the East Coast, it is the rage, but there may be some benefits. How often would you counsel somebody in a clinical space to actually check testosterone MS levels? And where would you want to keep that range? Because I know that that's kind of a big thing that comes up.
Okay, so there are a couple of points there. That number one, when we measure testosterone, we're not trying to find low testosterone. We're looking either for women, we're investigating for androgen excess or overtreatment. So everyone talks about mass spec, but you can use immunoassay satisfactorily to find high testosterone because you're looking for high testosterone. Based on our safety data and I've done studies with patches, gels, creams, inhaled, I've done studies with all sorts of testosterone. If you keep the upper limit if you keep the testosterone level within 50%, take the upper reference range and not exceed 50% above the reference range for that lab. Every lab has a different reference range. Every lab uses a different platform. So you can't even compare mass spec between labs. So we say within 50% of the 50% above the upper limit of the reference range for the lab.
That's really helpful. There's a question that came in. Can you discuss the approach to women with subclinical atherosclerosis? I don't want to assume, but I think that they're meaning in terms of hormone therapy, and if somebody has that subclinical atherosclerosis, can you give them hormone therapy? And if that's not the interpretation of the question, please raise your hand or follow up in the Q&A.
There's one study that has looked at this and looked at the number of did a whole lot of angiograms and coronary artery calcium scores. And if you look at the data very clearly, they were in that population with subclinical atherosclerosis. It was an observational study. They were not able to very clearly demonstrate that there was any harm. However, that would be one population, just like diabetics. I would only use non-oral estrogen.
Yeah, and kind of a follow-up to that, as the American Heart Association is changing their guidelines and really recommending those lipoprotein A, LPA levels, and ApoE, and How do you see that interacting with research in the future? Would that be a subset of women, particularly in their perimenopausal transition, that should be studied differently when it comes to that metabolic piece? And would that be somebody higher risk in the future to consider?
Oh, that's opening Pandora's box. I mean, the first study I published that sort of um, accelerated my career, we did a randomized placebo-controlled trial of women with hypercholesterolemia and randomized them to a statin versus oral estrogen therapy. And we showed that the oral estrogen therapy was more effective at lowering LP little a than the statin. The statin did nothing. And the more androgenic progestogens actually lower LP little a quite effectively. So I think, and then you couldn't publish anything with HRT for about 5 years after WHI came out because no one wanted to talk to you. And that sort of all went into the back burner. But I think then it needs to be a lot more examination of, and that was with Premarin and Provera, and we had a great effect on LP little a and a fantastic effect on HDL cholesterol. So what can I say?
No, and it's so interesting because again, the topical bioidentical, I think that's a really big take home that it's not the same.
It's not the same. And, people pick at WHI and they throw out what they don't like and they keep what they like and then they transplant that to bioidentical hormones and they're not the same. You
Yeah,
can't do that.
there's a
Not
question. There's a question that came up, and I think this is a loaded question. How much damage did the WHI study do?
You know what? I was one of the naysayers that sort of panned it and said it done all this damage. I think we actually learned a lot from that study. And I think if you take your emotions away and look at the data, there's so much information there. I mean, the bone protection is very clear. Um, and in fact, I think considering we don't like giving progesterone, we really understand that even if you give Premarin and Provera, a prothrombotic estrogen, it's very hard to do a lot of harm. It just didn't prevent heart disease.
Right. And that's the take home. The prevention and harm have to be parsed out, not that it's going to be the cure all for everything. And I think another important point is that vasomotor trigger biomarker, especially with sleep. So if you can get women sleeping, their health benefits are very extensive.
Oh yeah, I mean, we've just, pulled apart our because we've got data in 8,000 women we just recruited across the country. And this is what my team's just pulled apart recently, so this is not published, but everything moves with vasomotor symptoms, and vasomotor symptoms really account for most of the sleep disturbance that's being seen. And we know if women are not sleeping, it affects their cardiovascular health, it affects their weight, it affects their cognition. So, estrogen may not necessarily directly improve cardiovascular disease, but it may make women healthier or feel better so they can be healthier, exercise more, be more cognitively, on tap sort of thing.
No, I mean, and if there's any other questions, please throw it in the Q&A. Professor Davis, I could talk to you all day. This is absolutely incredible that we're actually having these discussions. And 5 years ago, there's no way that this would be as hot at it as it is now, every pun intended. We're getting comments that this is a wonderful talk, not a question. And it that is absolutely going to be the feedback. This recording will be shared. We do have a collaborative when it comes to menopause care, going through difficult cases. So this will be part of our discussion to share these slides and really recalibrate the discussions when patients are coming in. So thank you so much.
Oh, it's an absolute pleasure. And I'm just thank you for having me present and share our work.
No, we are thrilled and hopefully ways to collaborate. If there's any other questions or things that come up for Professor Davis, please let us know. We are so grateful for everybody that joined us. Our weather is now in the summer mode, so we are hitting 90s today, and it looks
Well,
like if you, yes, if you have to get to The outer boroughs, it will happen later today. The strike has been lifted. Our next time that we will reconvene, it'll still be in the summer mode on September 1st. And if anybody has any questions or concerns, please let us know. Don't forget to do your CME, and we will see you guys. Have a beautiful, healthy, and happy summer.
Thank you very much.
Thank you so much.